So odontoid fractures are certainly among the most common fractures that you will encounter in clinical practice, and nearly all of the clinical questions will pertain to type 2 fractures. And a great deal of interest in the literature over the last 2 decades has been directed at the concept of a fibrous union. The ideal outcome from a type 2 odontoid fracture, whether it is treated surgically or non-surgically, is to achieve a bony union. But although surgery offers higher rates of fusion, it comes with the risk of surgery, and here is where the catch-22 comes, that the patients who we frequently see are the elderly. They may be on Eliquis or have a lot of medical comorbidities, and they're the exact patients that we would rather not operate upon. So if a patient, after being in a collar 3 months, develops a fibrous union, is that considered to be a satisfactory outcome after type 2 odontoid fracture? And although controversy is not eliminated, I think in this particular area there is a consensus that is emerging that a fibrous union is a satisfactory outcome that is generally associated with a good clinical outcome and similar clinical measurements. Now, when we're talking about developing a fibrous union and being happy with it, we are speaking about patients that could be treated either surgically or non-surgically. We're not talking about patients with significant displacement or spinal cord compression that certainly need surgery. A controversy, though, that has not been settled is what is the effect of surgery and does it reduce mortality? Odontoid fractures are not entirely benign, and if you look at the data, like hip fractures, there's a significant mortality in the first year following fracture. So a surgeon has to weigh the benefits and the risks of whether surgery is appropriate for a particular patient, and that may depend on the patient's medical comorbidities. It should be kept in mind that non-surgical treatment has its own comorbid or own problems. Putting a patient in a halo vest is very difficult for an elderly patient that you may develop dysphagia, or respiratory compromise, and even collars have their own problems. So when surgery is needed, there is an anterior option, the odontoid screw, or posterior options. The decision as to which way to go is much larger a discussion than for this talk, but suffice to say that a much smaller number of patients are appropriate for an anterior approach because you have to have the right alignment and you have to have the right patient body habitus. So one area that we identified that has been discussed more recently in the literature is that the odontoid screw is not an entirely benign procedure for elderly patients, and these patients seem to have a much higher rate of dysphagia. And I can say anecdotally that many of my colleagues have had second thoughts about offering odontoid screws for elderly patients. It turns out that odontoid screws work great for patients who are the same patients who would have probably healed very well in a halo. This is a very interesting idea, and there are a few papers now that are looking specifically at the idea of maybe giving a patient an internal halo, putting in posterior instrumentation with the intent of coming back to remove them once the odontoid fracture heals. And the advantage of this strategy is that you do not lose the range of motion of the C1-2 joint, or at least you have the potential of maintaining motion, which is a very important motion segment. Another advantage to this approach is if you needed more fixation, there's no reason that you would not be able to go up or down to achieve additional points of fixation. I think that the idea of navigation being of benefit in performing surgery in the upper cervical spine should not be an area of controversy, and I think that it has shown its value in lowering the rate of vertebral artery injury and achieving more optimal fixation. Even in anterior approaches, I think that this can be a helpful technique. If the setup that you see in this slide seems like a lot of work, I will point out that using 2 fluoroscopies for an odontoid screw is also not very much fun to set up. This topic, the topic of optimal graft material, continues to be a debate in all forms of spinal surgery. Certainly, iliac crest autograft is still the gold standard, but I think fewer and fewer doctors are actually going to the iliac crest and harvesting. They're using demineralized bone matrix or other bone graft substitutes, and the literature is still really all over the place in terms of head-on-head comparisons and what really is an acceptable or desirable bone graft. Thank you.